So let's talk a little bit about the plans for next coming year and also in the long term. I say that at times like this, it's always important to stay focused on our mission and to prioritize accordingly. So I'm putting up here the mission statement to remind ourselves what we're about. And I think it's very clear that you can see that we want to be leaders in transformation of medicine, locally, nationally, and globally. We do this through innovation, scientific research, a very important part of what we do, translation of these breakthrough research, and of course through DTMI and others, we're accomplishing that, educating future scientific and clinical leaders, advocating and practicing evidence-based medicine, improve community health, and leading efforts to eliminate health inequalities. I'm very proud of this mission statement because so much is written and others in a very bland way saying we want to be the best in research, clinical, and training. We want to do more than that. We want to be leaders in all these areas in changing the way medicine and healthcare is practiced, changing our knowledge about biology and disease, and importantly, we want to eliminate health inequalities. And I think we've been doing this well through implementation of bench to bedside to population, the translation research approach, which I call the innovation to care continuum. We also, at the same time, run a vertically integrated healthcare delivery system that integrates community-based care to highly specialized quaternary care in a seamless enterprise. I think that's what puts us in a very good stand. In moving forward, I'd like to first talk about what we can expect from our academic enterprise. First, we'll continue to make investments in our faculty and our programs. And it's important, therefore, to have financial stability of the School of Medicine. And again, I want to commend Dean Andrews, Scott Gibson, Sandy Conduit, many others for working so hard to make the school work efficiently. But they don't have all control over their environment. With the endowment losses and investment losses, the amount of dollars coming to the school is substantially less. We've lost the support called Strategic Investment Fund from the university because they lost so much money. NIH funding continues to be flat. And so we have to find a way to work collectively to balance the budget. And they've implemented many steps towards that balance. But importantly, we are one Duke medicine. And it's important to remember that we succeed and fail together. Consequently, last month, the Board of Directors of the health system is committed to backstopping the school financially so that Dean Andrews can continue to invest in the strategic priorities. I hasten to point out to you that doesn't mean it's business as usual, and she'll be the first one to tell you. But it does mean there's greater stability whereby we can draw on the 280, at least in a more robust fashion than what we have to do we cannot. So that towards the later years, there will be a backstop. Absent this backstop, the Dean's ability to continue plan spending and investment would have been exhausted school resources. So the plan would have to decelerate spending over the next few years. So I think that this is a very important point. And I think that in doing so, we're achieving two major objectives. First, we're assuring that the school's operational ability to pursue and fund people and programs will maintain its ranking as one of the top medical schools in the nation. Secondly, it provides a perfect illustration of the organization's commitment to shared success of all of Duke medicine and a tangible recognition of the interrelatedness of all entities in our collective, to our collective success. The medical school is characterized by strong basic science and clinical research, outstanding and innovative medical education, and excellent departmental leadership is key to the excellent reputation enjoyed by the Duke University Hospital and the health system. And the health system's tremendous track record of excellence in patient care and clinical services often an important drawing point and selling point recruiting basic and clinical researchers to the school who share our vision of translation. This coming year, we'll continue to recruit and retain new faculty, but our first focus is to complete recruitment of key unfilled basic and clinical department chairs, and then to move forward with recruitment of key scientific and clinical faculty in accordance with the priorities of the Dean's Office and these chairs and institutional leadership. We'll continue to invest in bridge program, funding program that's been so important to many investigators at a time in which funding can be disrupted. We are committed to continue to invest in the Chancellor's Scholar Program, as described earlier in my talk, as it turns out to be an incredibly productive investment for scientific enterprise at Duke. We also will invest in needed infrastructure. With the guidance of Dean Conbluth, we look at a series of areas that we believe we should be investing in. This will include the IPS core, inducible pluripotent stem cell core, a facility championed by many basic and clinical scientists. The Duke Biobank, which is driven by an effort driven by Sally Conbluth, Krishnan Idabakuma, Mike Hauser, Jeff Ginsberg, and Rob Califf, and also the Translational Cell Therapy Center being developed by Nelson Chow, Jen Kurtzberg, Bruce Hellinger, as facilities and core lab to help our investigators to support their work. And a key to investment in the schools in coming years will be adjustment to strategic priorities. So to better focus our priorities, given now the next 5 years looks quite different from the last 5 years, I asked Dean Andrews and Gillis to rework the 5-year strategic plan to reflect forward thinking, particularly in their ambitions in a world that's entirely different than, say, 15 months ago. Critical to this plan will be education and research and faculty laboratory space. Dean Andrews and I are committed to construction of a learning center facility, and in fact, the planned facility has been initiated and is moving really full speed. And next month, in fact, we'll be launching the whole idea in front of the Medical Alumni Council. Dean Andrews is actively pursuing options to address the need for lab space in the short term, and she and I remain committed to the concept of developing and constructing a signature research building in the not-too-distant future. We believe this has to happen because in order for us to maintain our competitive edge for scientists, space is really a very important commodity we must have. So we're going to find ways to address that again about research building. And earlier I shared with you some of the notable educational successes that I take pride in. Well, next year we'll be increasing the class size for nursing school and the PA programs, really in anticipation for the great demand for health professionals, particularly as we look at new models of primary care, the important role that these healthcare professionals take. In addition, we'll be looking whether it be possible, building on the work of Colleen Kuchowski and the interprofessional collaboration education they call ICE, together with Dean Buckley, that includes representatives from all allied health and graduate professional schools, School of Medicine, Nursing, PA, and others, and to develop a training program that emphasizes team-based training and multidisciplinary care delivery approaches, thereby educating our students in the new care models of the future. It's also an important year because we are now kicking off an inaugural year for this new program for residents called the Management Leadership Pathway, and which the program director is Bill Fulkerson, and my cover is involved. It's a program that lets MD, MBA students graduating from the medical school with due degree to enter a residency program, any program. We have to be obviously selective. We can't fund everybody. So that they will get the full clinical training, as well as, in fact, hands-on management experience. So when they're done, they will have the skill set to be great leaders in medicine. So I hope you share my confidence in our ability to move forward with this kind of plan at a time when many of the country institutions are hunkering down. We have been prudent in how we spend our money, but I think you can see the priorities that Duke Medicine leadership has in the academic side. We also have very clear plans for the clinical success. And first, this is, by the way, a nice rendition of the Learning Center, which is in fact to be located next to, right here, the Searle Center, I believe, reflected over here and also connected over to the new hospital addition. So this, in fact, is very much along the way. As you remember, Duke Endowment has given us $35 million, so we are hopefully more than halfway towards the goal for this learning center. So on the clinical side, it's important that we continue to grow in our clinical volume, because growth is critical to our future success, so that we can not only serve the people who need this care, the baby boomers and the people who demand care, but also is an important source of revenues to pay for our new programs and facilities. As you can see here, first, we have announced that we are going ahead with the building of the Duke Medicine Pavilion and the new Cancer Center. And this is not done, without a lot of hard work by our CFO, with the Board of Trustees, with many of you. I've actually sent notes to you to say, please tell us your input, whether it's the right thing to do, because it is very pricey. But to a person, people say you have to invest in the future. And here you can see a rendition of the new Cancer Center and the new hospital, or the hospital pavilion. We'll break ground in November for the Cancer Center. That will be completed by mid-2012, whereas the Duke Medicine Pavilion will be open in 2013. So between now and the hospital expansion, we have to maximize our capacity management and ramp up strategies to partner with the regional hospital. And we are currently working in operation solutions to manage capacities. The expansion and capacity management efforts related to Duke Hospital and the regional hospital comes at a time when we continue to expand into Wake County, and with Duke Riley Hospital serving as the focal point. The performance of our Duke Medicine Plaza in Raleigh, as well as several new open facilities, clinics in Broward Creek, Morrisville, and Knightdale continue to validate the strategic importance of our Wake strategy and success of our ambulatory and outpatient strategy. And I want to make sure I give credit for so many people who've done the work, Molly O'Neill for putting the strategy together with leadership, Paul Newman and Doug Vinso, and many others for implementing this. We'll also be pursuing improved alignment within and among the disparate entities of Duke Medicine. I told you how important it is for us to function as a team. So this will include a whole series of considerations of not only how to pull school medicine, health system, school of nursing, and PDC closer together in enterprise level of planning, but also in consideration of new organizational structures, which include integrated service lines and centers. I'll mention a word about Cancer Institute later. But also the whole range of purchase service agreement, employed physicians, and other forms of functional alignment. We're prepared to do this in order to place us at the very best position to be an organization that can work seamlessly as a team to provide excellent care to our patients. We're working with department chairs and Carl Raven, the president of PDC, to develop faculty compensation plans that are transparent and performance-driven. And we're studying better ways to support faculty so that aligns with incentive, mission, and compliance with the Stark Law. Now, I think it's interesting, if you think about healthcare reform, there is a discussion, in fact, whether Stark Law could be modified in order to have physicians, hospitals work much closer together, look at savings and improve efficiency. So I think overall we are going to take an enterprise planning approach, one that David Epstein pointed out to us, one that engages health systems, school medicine, nursing, and PDC together. The other very important thing we need to work on is operation efficiency. Last year, when we realized, of course, that reimbursement is going to be tough and change that foot, Bill Fulkerson, Ken Morris, and with the leadership of many of you, look to find $50 million of margin improvement. And I was really impressed how effectively all of you stepped up to the plate and did that. Well, I think this year they have more in store for all of you. But I think this is all really done with the best of intention to see how we can be even more efficient. Certainly we can look at a lot of opportunities such as operations within hospitals, including length of stay, decrease all our turnaround times, clinic wait times, reduce no-shows, and improve capacity management. I also want to point out we actually have to be innovative and create new approaches to performance imperatives. For example, if readmission, and even if it's not, readmission becomes part of the new healthcare reform, we've got to start looking at how we can best manage our patient to prevent readmission and to improve post-discharge disease management. And there are so many other things that we can be doing. Now, we all believe that ultimately the quality of care we provide patients is paramount, and that's what we're interested in doing. So the creation of accountable care organization is something that we've been aspiring to, with a little bit of trepidation. But if you look at how we're functioning, in many ways we're already beginning to do that. So we are now in discussion with Mark McClellan at the Brookings Institution, the previous FDA and CMS commissioner, and also with Ellen Debson and our own Dzau with Carl Kavanaugh and others to talk about whether we can actually develop ACOs within Duke for our own employees, which will therefore increase and improve the healthcare, but at the same time create savings, or perhaps looking at, the CCN network that we are responsible for. I think these are very important initiatives that we must follow up, because it will change the quality of healthcare as well as reduce the cost. And of course, there are so many other things I can talk to you about. Derm health innovation, the work done by Lloyd Mitchell and others on connected health, and the teamwork that I talked about earlier. So I just want to recognize the super job our people are doing, and really we would not be here, our academic and clinical enterprise, had it not for the leadership of my team and also for the great work that many of you do.